Now we're going to get into mycology, everybody, which is the study of fungi, right? When you think about fungi, are they eukaryotes or prokaryotes? Eukaryotes, right? Remember, you are fun. Yes. Remember, we said fungi have different divisions, which are going to be yeast and molds. So as you look at this visual with me, you want to think again, fungi are eukaryotes, right? They can reproduce asexually and sexually. Glycogen is going to be their main fuel source. That's been on old tests several times. And if they ask you on the test, what type of auger do you see with fungi, you want to pick Sabarod's auger, right? Think of SAB at the beginning of the word, like you're driving a Saab, SAB, a car. It's a fun car to drive. Associate that with fungi as well. As you look here in your notes, you're going to see a few pointers here on yeast and molds. As you look at this visual with me, the key thing I want you to know about yeast is think of yeast as being unicellular, right? Unicellular, but yeast yearn, if you play with that word a little bit with me, they yearn to be more, right? So they yearn to grow, so they can grow both sexually or asexually, okay? That's a key thing to know. And either way, sexual or asexual, it's going to produce spores, okay? And by the way, who did we say produces spores earlier? Remember what it was, everybody? We said, yes, anthrax and Clostridium. Yes, those are the big ones we keep stressing, right? So put this next to it in your mind, yeast as being an example of that as well. When you look at molds there, guys, you can see molds are multicellular, not unicellular. Remember, yeast are unicellular, molds are multicellular. That's the key differentiation. Molds, when they kind of join together, they can form hyphae, right? And those things are what's been mentioned on old tests. Unicellular, multicellular, the fact that yeast can do asexual and sexual reproduction that forms spores. Again, this is not a high yield portion of the notes. I'm trying to summarize just the take home messages really quickly for you. The next portion of our notes, everybody, is talking about mycoses. And you want to skim through this quickly because you're going to be thrilled to know this has not been stressed much on old tests. I don't think this is much use of your time. When you have 13 questions in this whole section, this is literally kind of like a waste of your life that you'll never get back. So I wouldn't spend a lot of time on this. You can see the notes goes from like cutaneous, actually superficial, to cutaneous to subcutaneous. Go to systemic where it talks about histoplasmosis. That's going to be worth your time and something you want to pay attention to. And if I had to stress kind of the key thing I would point out, just look in your notes with me, it's going to be that it's prominent in the Ohio, Mississippi River valleys, right? The other thing I would want you to know is that it's found in like flighty things like birds, bats, chickens, right? You want to think of histo as being common in those situations. As we get into this last section here, which is opportunistic yeast and molds, look at this visual with me because I'm going to summarize this quickly. Candida is the one you really want to pay attention to. Okay, Candida is going to be the most common, right, in the mouth, the most common microflora in the mouth. It has the largest proportion there. When you think of Candida causing oral thrush, you want to know that it's most common in what type of patient? Immunocompromised, yes, or patients with too much antibiotics, all right? That's going to be the classic scenario on why they would ask Candida, so pay attention to that. This next one, which is Fumigatus, I always look at the word fumes right there, the F-U-M, fumes, and I think lungs, okay? Because any question on that would be going after a fungus that's going to happen in the lungs, okay? So you can see there the bronchopulmonary aspergillus, right? The lung cavity issues, right? So pay attention to that on the test. The other one I would pay attention to is mucor, okay? So mucor and Rhizopus species. Pay attention to, if you see that word mucor, in particular mucormycosis, stop reading the question. They're probably going to go after the fact this is a problem that happens in diabetics, okay? That's a fungal infection. That's really what I would pay attention to, mucormycosis. Stop reading the question, think diabetes, think fungal. As we get into parasitology, this is another really, really low yield section. You really want to skim these quickly and you want to get right to Giardia and toxoplasmosis, okay? Now they could ask you a question on the others, but I would be surprised and I wouldn't waste much of your time on it. With Giardia, I want you to look at this visual with me for a second, okay? This will help you remember it's heart-shaped, it has flagella, and it has two central nuclei. Okay, that's kind of the main thing I would pay attention to as you look at it. Toxoplasmosis, I love to talk about this one. This is a great condition to know well. It's been on old tests a lot and I love it. Look at this flow chart with me. With toxo, you want to think someone's going to get toxo, first of all, through eating undercooked meat or inhaling cat feces, okay? It's almost always going to be passed on, right, in a congenital transmission, meaning the mom passed it on to the baby. That's 90% of the time. The other 10% is acquired, meaning you ate the undercooked meat or inhaled the cat feces, right? But I want to look at the congenital because this is where it's most likely to be asked on a test. With congenital transmission, most of the time the mom passes it on to the baby, 90% of the time, no big deal, the baby's fine. The other 10% of the time though makes for a great board question. Okay, this is what's called, well actually the way to think about it is this congenital transmission can cause mental retardation, right, or cerebral calcifications. This is why you've heard of what's called a torch titer. Okay, these are 5 conditions that can result in a baby being born mentally handicapped from an infection, okay? And that T is toxo, and you want to know that really, really well. The others you can skim quickly, but that's what I would really know for this test is toxo. That's what's likely to be asked. Okay, everybody, this is going to be awesome. Antimicrobials, I love this probably as much as anything we teach. I think we can really simplify this quickly for you guys. And I want to start by just giving you kind of a big picture understanding of this. When you're talking about how you would affect bacteria, you can really affect them in one of 3 ways. Number 1, by affecting their DNA. Number 2, by their protein synthesis. And number 3, by their cell wall. And so if you have that big kind of scaffolding in your mind, DNA, protein, cell wall, you can, if you were having a dorky conversation with a friend about antibiotics, you could literally categorize them all in one of those 3 categories. So I'm going to start off with DNA with this visual with you guys, okay? When you think of DNA, we can mess with bacterial DNA through folic acid synthesis or through fluoroquinolones, okay? Those classification of drugs. So we're going to start with folic acid synthesis. And you'll see this layout in your notes in terms of words, but I'm going to show you in a visual here that with folic acid synthesis, you start off with a molecule called PABA, P-A-B-A, and that is converted to dihydrofolic acid. And you do that through an enzyme called dihydrosynthetase. When you see that enzyme on boards, the number 1 drug that's going to attack dihydrosynthetase is sulfa drugs. Okay, so sulfa-synthase, right? So sulfonamides, for example, the mechanism of action is going to be to inhibit dihydrosynthetase. You probably remember that Stevens-Johnson syndrome is a condition caused by sulfonamides, right? And a hypersensitivity to sulfonamides. So pay attention to that if you see that. But when you think dihydrosynthetase, think sulfa. Now, dihydrofolic acid can be converted to another compound called tetrahydrofolic acid. And that is done through the enzyme dihydroreductase, right there. When you see reductase, when you see that on the test, think reduce, right? Reduce, think trim. Because if you think trim, right, I want that to be trimethoprim in your mind, trim, right? And that should trigger a mnemonic, okay, which is treat marrow poorly. Those 3 drugs, trimethoprim, methotrexate, pyrazinamide, those 3 drugs, okay, are going to all do the same thing, which is to inhibit dihydroreductase. Now, when you think of these 2 steps, dihydrosynthetase, who stops that again? Sulfonamides, right? And then you think of dihydroreductase. Whenever you say reduce, you're thinking trim, right? So each one of those, the first step, again, sulfonamides blocking that. And then the second step, TMP blocking that. Those drugs are going to be synergistic. They can work together. So you're going to see Bactrim and some of these other drugs as being combination of the first and second step of folic acid synthesis, okay? So guys, when you think of stopping DNA, first of all, think folic acid. The other one, you're going to think fluoroquinolones, okay? With fluoroquinolones, and again, I'm giving you the big picture now to kind of draw this out and to think about it. Then I'm going to allow you to kind of pepper through your notes on your own and kind of get the other finer details. This will get you a long way there, though. When you think of fluoroquinolones, I want you to think 2 mechanisms of action, okay? You're going to see it stops DNA gyrase and stops topoisomerase 4. That's the 2 mechanisms of action. Fluoroquinolones, you want to think of those, there's a couple different generations, right? I want you to think of the second generation like CO2, carbon dioxide, CO2. Ciprofloxacin, ocufloxacin, right? The flox is always going to be in the word. When you get to the 3rd generation, I want you to think levofloxacin, okay? Levofloxacin. Think of it like a 3-leaf clover. That'll help you remember the levo as being the 3rd. The rest of them are all going to be 4th generation, okay? When you think about these drugs, all generations are going to be good against gram-negative, okay? All the generations, all the drugs. But as you get higher up, as you get into the 4th generation, you're also going to add the ability to dominate gram-positive as well, okay? That could be a test question and something I would hone in on. But as you're differentiating the 2nd and 3rd and 4th generation, I would know the 2nd and the 3rd and all the rest are going to be 4th. That's an easy way to do it. So 2nd, again, are going to be CO2, the 3rd, LEVO, the 4th are all the rest, all right? That's kind of the way I would think about DNA synthesis. It's all about fluoroquinolones, all about looking at folic acid. Now we're going to look at cell wall synthesis inhibitors. Guys, this is going to be a hot topic on the exam. I would pay attention to this. When you think of cell wall synthesis, you want to break it down into thinking of a cell wall, first of all, as being like, think of it like a log cabin, okay? And there are logs, and then there's glue that holds the logs together. So when you think about this practically, you want to think some of the drugs that are cell wall synthesis inhibitors are going to attack the logs, some of them are going to attack the glue, okay? When you think of this in terms of like academic or how they show it on the test, look at this visual, you'll see kind of how they would represent this. When you think of the logs, you want to think of that as being peptidoglycan. The other term they might use on boards is called mucopeptides, right? That would be the other term I would pay attention to. But bacitracin is going to be your drug that stops that. Okay, not nearly as commonly prescribed as the next one, which is going to be transpeptidase inhibitors. This is the glue that holds it together. When you think transpeptidase, you want to think penicillins, cephalosporins. Always say those together in your mind. Penicillins, cephalosporins. Because you probably remember that they both have a beta-lactam ring, okay? They're very similar in structure, okay? That's not the exact same ring, but they both have very similar structure. You probably remember in school that if someone's allergic to a penicillin, they have cross-sensitivity reaction likelihood of having a problem with cephalosporins as well, right? There is some cross-sensitivity. So if someone in your office ever one day says, I'm severely allergic to penicillin, right? Then you want to not prescribe a cephalosporin as well because of that concern. But you'll hear a lot of patients say they're allergic to penicillins, and you don't want to freak out about every one of them because sometimes the reaction is just very mild, okay? But bottom line is, on boards, if they ask you about a penicillin hypersensitivity reaction, you want to think IgE. You want to think about type 1, okay? That's going to be the one with histamine release and vasodilation and bronchoconstriction and all that good stuff, okay? So again, in terms of a penicillin reaction, which would be like the number one reaction from one of these drugs that they would ask, think type 1 hypersensitivity reaction, okay? But when you think about transpeptidase, you want to think penicillins, cephalosporins. As you get into the notes, you're going to see penicillins. One of the types we're going to look at is amoxicillin. Now, we already talked about this. Amoxicillin is broad spectrum, covers positive and negative, right? But it's not penicillinase resistant, so it's susceptible. So we have another drug where we wrap a C around that, and now the drug's called clavulanic acid. Good job. Yes, you'll be all over that on the exam. That's big. The other one I would pay attention to is looking at decloxacillin. Decloxacillin is going to be have one disadvantage compared to amoxicillin, and the disadvantage is that it's going to be just gram-positive specific, right? It's not gram-positive and negative. But the one advantage it has on amoxicillin is that it is penicillinase resistant, okay? So that's how you want to think about diclox and amoxicillin. The other one we want to look at is cephalosporins. And as a reminder, guys, with cephalosporins, the first generation cephalosporin, do you remember what it was? It's going to be cephalexin. Again, that's Keflex, right? Remember, that's highly gram-what specific? Gram-positive, yes. Whereas the third generation is going to be ceftriaxone, right? Rocephin. That's going to be used to treat gonorrhea, okay? So what is this going to have to be specific against? Gram-negative. Good. You remember gonorrhea was a gram-negative diplococci. Yes, good. Okay. So bottom line is, when you think of these drugs, cephalosporins, all of them are going to be good at gram-positive, right? But as you work your way up in the generations, you need to be more gram-negative specific. Ceftriaxone, again, needs to be good at gram-negative because it's used to treat gonorrhea. Okay, that's the big picture on that. So again, what we're trying to do is categorize these drugs quickly. And last but not least, we have drugs that are going to affect protein synthesis. Okay, guys, you want to know these well. We've used this mnemonic a few times throughout the course. First of all, you want to buy low. Buy low is at 30. You want to sell high. Sell for 50. So the at 30 you want to pay attention to is aminoglycosides and tetracyclines. Okay, aminoglycosides, tetracyclines are going to act at the 30S ribosomal subunit. A couple reminders about tetracyclines. Remember, do you guys remember doxycycline, what that's used to treat in the body? The big one I would pay attention to is chlamydia on the test, okay? You also know that the tetracyclines, don't miss this guys, okay, huge. The tetracyclines are contraindicated in children, right, and in pregnant women, right? Because of the concern of bone retardation, right, discolored teeth, photosensitivity. Those things are in the text, but the big one again is obviously going to be discolored teeth for us that we want to make sure we hit on the test. When you think of cell at 50, the CEL, the C is going to be chloramphenicol, right? The E is going to be erythromycin, and the L is going to be lincomycin. Okay, that E of erythromycin, hone in on that, because it's not just erythromycin, it would also be azithromycin. Okay, these are the macrolides. These are the absolute best drug you could prescribe in someone who's pregnant. If they ask you like the safest possible drug, it's going to be those drugs. Erythromycin, azithromycin would be the classic one they would ask. So pay attention to that in case they ask it, okay? But that's going to be the drugs, again, that affect 50S subunits. Now, the big picture on this, okay, whether it's at 30 or cell for 50, they affect the ribosomal subunit, right? Which means they're going to affect protein synthesis. That's the big thing that they could easily say. Which of the following drugs interrupts protein synthesis? And your answer would need to be, any of these drugs, okay? Any of these that affect 30S or 50S subunit. All right, guys, now we're going to get into tuberculosis medications. As soon as I say tuberculosis, I hope you think caseous necrosis, right? I hope you think night sweats is going to be the #1 issue in these patients. And I hope you think in terms of the PPD test, which is used to test these patients, that you're thinking of hypersensitivity reaction, and that's going to be a type 4 hypersensitivity reaction. And when you say that, I hope you're thinking about T lymphocytes being the culprit, and in particular T killer cells, which have CD8 receptors. You'll see that in the immunology video, all right? That's the big stuff you want to know about tuberculosis. Now, when it comes to treatment, you want to know that the main drugs, again, are going to be this. Now, look at this visual with me. You got RIPE, all right, RIPE. Now, in the text right here, we don't have the P, which is pyrazinamide, but a lot of times people use that mnemonic. The R is going to be rifampin, and I don't know that they'll ask you this, but I would know rifampin RNA polymerase is going to be the drug. Isoniazid, some textbooks will talk about how this can be used in isolation. It can be used by itself. It doesn't have to be combined with some of the other drugs, the RIPE drugs. Okay, but ethambutol is the last one I would pay attention to. Okay, these are just in general TB drugs that they could ask on the test. As we get into antiviral drugs, I want you to pay attention to Hep C with me for a minute. Okay, as you look at this heading, you're going to see ribavirin. Everybody see that? Now, the key thing I want you to remember about Hep C is, do you guys remember, is there a vaccine available for Hep C? The answer is no, right? It's only for Hep A and Hep B. You do remember, though, that Hep C is the one that's chronic, right? So it's going to need treatment. That's where this drug comes in, ribavirin, all right? Now, as we look into the anti-herpes virus drugs, one thing I want you to kind of enjoy about these drugs is that they all have the same mechanism of action. They all are DNA polymerase inhibitors, okay? Every one of these drugs, kind of pause on that, whether they ask you about valcyclovir, famciclovir, Viroptic, any of those are all going to be DNA polymerase inhibitors. Okay, guys, now we're going to talk about antifungals. And when you see antifungal, I want you to think ergosterol. That's like the main component of their cell wall. And when you think about that, I want you to immediately think all these drugs we're going to talk about mainly have to do with ergosterol. Okay, so as we look at these together, the first group is going to be natamycin, amphotericin B, and nystatin. They bind to ergosterol, right, and literally create pores to allow fluid to come in and burst the cell. The big one you need to know there is going to be nystatin, okay, because of using for candida, which causes oral thrush. Remember we said earlier when we talked about candida, it's going to be the #1 fungus you want to know about in terms of causing oral thrush in immunocompromised patients or patients on long-standing antibiotics. As you look at the next group there, you're looking at the azole drugs. Again, ketoconazole, that's a big giveaway right away for fungal. And when you see that, again, it has to do with ergosterol, okay? So ketoconazole was going to be your first, but just pay attention to ergosterol. Last but not least is greaseylfulvin. I want you to kind of say greasy microtubules, okay? Say that to yourself. Greasy microtubules, because this one doesn't have anything to do with ergosterol. It has everything to do with microtubule interrupting mitosis, okay? That's a unique thing about it. Again, most of the time when you see fungal on the test, you're thinking ergosterol. This is the exception. And sometimes exceptions, as you guys know, make for good board questions. The next big heading we're going to talk about, everybody, is anti-inflammatory medications. This is huge. You can dominate several questions in a row off this one diagram. So I want to show you the arachidonic acid pathway. And you guys remember this. I know you've had it multiple times, but let's review it and make sure you're ready to dominate it, all right? So it all starts with membrane phospholipids. Now, if you watch the biochem video, you'll know that the number one membrane phospholipid they like to ask about is phosphatidylinositol. Just remind yourself of that. If you can remember that on the test, you can be like, booyah, I'm the man, or I'm the woman, pat yourself on the back and be like, yes, all right? That's gonna be your main membrane phospholipid. You guys know there's an enzyme that converts that phospholipid into arachidonic acid, right? That enzyme is going to be phospholipase A2. Phospholipase A2. And bottom line is, if you can stop that enzyme, right, you can stop everything that's going to be remaining in this pathway. If you can cut off the head of the snake, so to speak, you stop all the things that are remaining, right? And you guys know there are two drugs that will stop phospholipase A2. One of them is going to be hydroxychloroquine, right, which is Plaquenil. The other one is going to be steroids. So that's why steroids are such good anti-inflammatory mediators, right? Is because they can stop the inflammation at the very, very top. All right, so think steroids is going to stop it at the top, but also hydroxychloroquine. Now, once you get to arachidonic acid, you can form leukotrienes on this side. You can also form prostaglandins and thromboxanes on the other. And you guys probably remember that the conversion of arachidonic acid into prostaglandins and thromboxanes is primarily done with COX-1, okay? You guys remember there's cyclooxygenase is COX, right? So if you can block COX, right, you're gonna stop prostaglandins and thromboxanes. Now, in general, it's going to be COX-1. Now, COX-2 also can be used to create prostaglandins that are going to be inflammatory mediators. Okay? The COX-1 is producing prostaglandins that are used to protect your stomach. So I want you to use this phrase, right? I want you to say COX-1 helps protect your one stomach, right? So prostaglandins are going to protect your stomach with COX-1. That's the key message. Prostaglandins protect through COX-1. You got that? That's the key thing you want to focus in on, right? Because you're going to see if they ask a specific question, like a particular drug that damages COX-1, that enzyme, right? Then you're going to end up getting stomach ulcers, okay? So you really want to know COX-1 is all about prostaglandins, and prostaglandins protect your stomach. Okay, that's the big picture on that. So as we get into steroids, you're going to see that heading in your book. Everybody see that? And it says systemic steroids can cause the following, right? You want to pay attention to this because it talks about this classic picture. Now I want you to look at this visual with me again. We've talked about this in biochem as well. You want to picture anyone who's been on long-term steroids, right, as having an increase in blood glucose. That's the big picture. If you increase blood glucose, right, you can gain weight. And when you gain weight, you can also increase your blood pressure. So picture this 65-year-old gentleman, right, it's overweight with diabetes and high blood pressure. That's the picture you want to picture on someone who has too much glucose in their system. Now remember, steroids increase your blood glucose. Now, you know it also does something to your bones. What do steroids do to your bones? They thicken or thin them. You're going to say thin. And if I said, what do steroids do in terms of your healing ability? It's going to decrease your healing time. So picture this 65-year-old diabetic, right, who's got a sore on their toe and it's not healing, okay? And that's because blood flow is reduced to that area. But the big thing, ding, 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 is that you're going to have a decrease in fibroblasts, okay? That's the key thing. That's what limits the amount of collagen and the ability to heal, okay? So that's something you want to hone in on. Make sure you know steroids, right? You've got to know the effects of steroids throughout the body. You know if you have too much steroids, that can be known as Cushing's syndrome. You have a cushion. If you don't have enough steroids, that's called Addison's, right? You need to add more steroids. Great. That's the big things I would pay attention to. As you look at those steroids, guys, you're going to see we have hydrocortisone, fluticasone, right? Those are some of the main ones. Remember the mechanism of action, inhibit phospholipase A2. So can steroids, by the way, guys, can steroids cause stomach ulcers? Yes, absolutely, right? Because you're knocking out COX-1, which is what produces the prostaglandins that protect your stomach. But also steroids are going to decrease your ability to heal and all these other things that we've talked about as a result of knocking out arachidonic acid. As we get into the NSAIDs, guys, the next category is going to be NSAIDs, non-steroidals. Now, as you look at these, the first thing I want you to pay attention to is just look at this visual that I created. When you think about NSAIDs, you want to group them in your mind as, first of all, aspirin is going to be irreversible. All right, all the rest are going to be reversible. And think of them in general in your mind is whether it's aspirin or all the rest, okay, you want to think of them as being inhibitors of COX-1 and COX-2. Think of it just as blanketing both, COX-1 and COX-2, because they could get really specific about those types of questions and bring it on. Just in general, it stops COX-1 and COX-2. When you think of aspirin, I want you to circle that IR in the middle of the word. I want you to think irreversible. All the rest of the NSAIDs, okay, I have a little mnemonic here I use, are going to be reversible, all right? So the N is going to stand for naproxen. Then you've got naproxen sodium. Then you've got Advil. Then you've got ibuprofen, indomethacin, right? You can see the main ones are all listed right there in the word NSAID. Again, you want to think reversible for NSAIDs. You want to think in your mind that it's going to block COX-1 and COX-2. When you get to celecoxib, that's the unique one, right? Look at the word, selective, the CEL at the beginning, selective COX inhibitor. And you guys know it's going to selectively stop COX-2, right? The phrase that I like to use a lot is Celebrex, that's this drug, Celebrex protects. How does it protect, guys? Because it doesn't affect COX-1. So you're still going to get your prostaglandins. That's how to think about this drug and how it's used. So guys, that's it. That's all of microbiology. I hope you loved that section. Another one bites the dust, another section we can nail and just really get all those questions on board. So go attack your notes, keep studying hard. It'll all be worth it. You'll be done with this. Pretty soon you'll be able to move on with your life. And remember, one of the things we stress over and over, it's not about passing this test. It's about just knowing these concepts well. I can't tell you how many of the things we talked about in this lecture I use with patients all the time. It actually affects the way I take care of people, and so I hope some of that stuff really influences your ability to do what you really want to do, which is not just pass a test, but be an unbelievable doctor.